All right, why don't we go ahead and get started, everyone. So welcome. This morning's episode quality improvement program meeting is underway officially. And I wanted to start actually by letting everybody know that yesterday, the state of Maryland had its annual meeting with CMMI. And essentially, the HSCRC does this every year. I think actually we missed last year because of COVID, but my recollection is that we do it every year. Or the state does it every year, the HSCRC does it every year, and they kind of talk about the update with the waiver and everything. The reason I'm mentioning, I guess I'm not supposed to call it the waiver, I guess it's the total cost of care agreement. Sorry, I'm not using good talking points this morning. But anyway, the whole relationship and the special situation in Maryland, and we had the meeting with CMMI, Liz Fowler and their team, and on our side, we had Secretary Schrader and Adam Kane and stakeholders and others. The reason I'm bringing it up this morning is in the 2-hour meeting, one of the things that really was clear is that CMMI was very excited about the alignment programs, the Maryland Primary Care Program, and keeping that going and getting that moving in a good direction going forward. But also there was a lot of excitement around the episode quality improvement program. And I just thought it was important to share with everybody who was working on this that there was this was not something that was an afterthought or something that they weren't focused on. And I just thought it was helpful for you all to know that. The other thing I wanted to let you guys know is given holiday schedules and everything, we're going to go ahead and skip the November meeting. I think we can get all the work done we need to get done, but we will be having a meeting back on normal schedule on December 10th. And I think that works well for everything. So having said that, those are kind of my introductory comments, and I'm going to go ahead and turn it over to Tequila to
Maddie.
if she has anything to add.
Yeah, Maddie's going to be running the show today, but I just want to relay my thanks to you, Jean, personally, as well as to the MedChi team, Dr. Edwards and others who were involved in that meeting yesterday. It was a lot of sort of effort to pull everyone together. And to your point, one of the key areas of focus that CMMI has talked about is this idea of one, multi-payer alignment, but then two, creating opportunities so that more, sort of non-hospital physicians can be engaged in payment reform and alternative payment models. And so with that being said, we continue to get reinforcement and positive messages from CMMI about the development of EQIP. So I just want to again thank MedChi for the partnership, as well as thanking all of you who've been on these meetings month after month as we continue with the planning. Today, we're going to start to look forward to what we have to think about in year 2. For purposes of designing the EQIP program. So I'm going to turn it over to the team, Maddie Jackson-Fowle, who you've heard from before, to start talking about how we are planning to look forward and think about year 2 considerations. So with that being said, Maddie, the floor is yours.
Thank you, Tequila. And thank you, Jean, for that introduction as well. There we go. So today for the EQIP subgroup, we want to go through an enrollment update for you all, and then also chat through some next steps for those who are enrolled in Performance Year 1. Then, as Tequila mentioned, we're going to turn to Performance Year 2 episode development. I know it seems very early to think about this, though, with enrollment starting next July, we're right on time, to kind of think about some new episodes and get them vetted and approved through CMS. So we will first discuss procedural and acute episodes. Here we really want to gauge where there is stakeholder interest. That's going to be a very critical component to us bringing on more procedural and acute episodes. Then we'll discuss if there's any interest in chronic episodes and what those look like, and any potential methodology changes or considerations we might want to make to the program to include them in EQIP. And then finally, we'll chat about our intent to just develop some emergency department episodes over the next couple of months. If you recall, the first iteration of EQIP did include emergency department episodes, though when we switched to the Prometheus methodology, there was not any available. So we actually will be working with Change Healthcare and other partners to develop our own episodes around emergency department utilization, which is a very exciting opportunity for EQIP to kind of be a leader in this episode space. As always, here are the contacts. If you need the Zoom or EQIP subgroup information moving forward, Barbara Fitzgerald at MedChi will make sure that you are on the list. And then any questions on policy enrollment or anything under the sun EQIP, please reach out to our partners at CRISP Health at equip@crisphealth.org. So just to give a bit of scope for performance year one, the 15 episode categories that we brought on covered about $1 billion of Medicare Parts A and B spending. This assumes 100% participation in all of those episodes, which we always strive for, though I do not think we reached with this first round of enrollment. But it is a significant amount of total cost of care spend in the state. So we're really excited that, just with these first 15 episodes, we have such broad potential for impact. This covers about 4,600 unique physicians or unique NPIs within the state and about 124,000 different episodes of care. If you wanted to roughly translate that to patients, you could, though some patients may have 2 of these episodes, et cetera. As of September 1st, we have 2,400 care partners who are involved in interventions and involved on a care partner roster for an EQIP entity and who were submitted to CMS for vetting. Again, no participation numbers will be final until 1/1/2022 when we get all the contracts through the door, but we're really excited that we've had such robust interest for the first year of this program. That's a significant amount of specialists, especially when you look at that we were only including 3 certain specialties in the first couple of episode categories. These 2,400 care partners are also split into 54 EQIP entities, so 54 distinct participation groups to drive interventions within. So broad scope within these 3 kind of buckets of episodes.
Hey, Madeline, it's Dr. Grasso. I have a question. I was told by our nurse care manager who we just hired to help us run this program that we are unable to drop specific episodes at this point. Is that correct?
Yes, as of now, your episodes are final, what you input into the system. If you have questions about that, though, please reach out to
my biggest problem is we never got our data to analyze. So we either have to make our choice of participating in certain bundles or not on your data. We spent a lot of money engaging a third party to analyze our data for us to see which episodes made the most sense. And if we can't, right now, I have a funny feeling we may not be signing our contract if we can't drop out of the hip fracture, pelvis fracture episode, because that's a big money loser, okay? So how can we be expected, and like Gene and I were talking about earlier, these small groups who don't have the wherewithal to really analyze the data independently, they've got to just take what you tell them at face value. Not that I don't trust you, but I'm a trust but verify kind of guy, always have been. So like I said, we have a third party vendor ready to analyze the data. You guys have never gotten us. So if I'm going to be forced to go into a episode that's going to be a big money loser for us, it may jeopardize CIO's participation in the program in total. Yep.
Well, so what I can offer is if you reach out to the inbox, let's talk one-on-one. And I will offer this to all participants who are feeling this bit of strain. We are building out these capabilities as quickly as we can as a state, though, with getting enrollment and EAP set up, it's been competing priorities. But if you reach out to our inbox, there are additional insights that we can offer. And if you let us know exactly what types of data parameters you're looking for, I can kind of see what's available off the shelf. I definitely don't want you guys to be making these decisions blindly. We do need to have the episodes that you are participating in final for contracting. Though I think that, we might be able to get you some solutions to your problems. So I hear you loud and clear that, that's important that you guys are able to analyze things and utilize contractors that you've brought on to support you in the program. So I know you guys have already reached out, but I'll contact you guys today to kind of talk about some options for that. Hear you loud and clear there.
Okay, thank you.
Can I actually ask a question too here? We had a couple smaller practices that didn't meet threshold or had issues, and probably in retrospect, it would have been better if they joined an EQIP entity. I'm assuming it's too late to have them join an EQIP entity if they've been rejected for threshold or out, right?
Yes, again, so I think we should talk offline about this. You know, if there was an opportunity to join an EQIP entity, everyone who was in the system as of 9/1 was submitted to CMS for vetting. So, you know, if there some of those entities that were too small to be able to, some of the entities that were too small to meet the thresholds, they were vetted to CMS, though it's, so we did offer that, and actually in our communications out to them, we said, if you want to talk about, you know, maybe joining another entity, please contact us. I don't think that we heard back from many of them, Jean, but we are happy to kind of entertain some options there. It's not too late, but we are getting very, very close to when we need to start sending contracts out the door. So I don't want to delay that process too much further.
Okay, well then why don't maybe you and I have a discussion, because if we could bundle a couple of them together, we might be able to get those small practices in and not lose them. And it was just another concern I had, and maybe we should have a discussion offline about thinking about having a catch-all EQIP entity or something, or having some third party do that, and maybe that's a role for MedChi.
Yeah, absolutely. And as with all of this, you know, enrollment for next year opens again next July. So we are, you know, less than, you know, 8 or so months away from when we do this whole thing again, and there's another opportunity to get in. So I think also a lot of these kinks could be worked out prior to then as well. So we've gotten into a bit of this, but through the end of 2022, we're going to work with CRISP and to ensure that, and participants, to get you final CMS vetting results. I'll talk about those a bit on the next slide. We're going to also complete the contracting and payment operations with and then continue our build out of the learning system and quality improvement supports that we want to provide so that participants can be successful in the program. So within those next steps, there are a couple of updates that we have. EQIP entities were all audited to ensure at least 75% of care partners included in your rosters had at least one claim connected to an episode baseline, a baseline episode. So that means at least one claim was showing up in that 2019 baseline. We set it at 75% to ensure that any new providers to your practice would not be excluded within the care partner roster. But we did need to reliably be able to check and ensure that participants would be connected to the interventions. And the way that we can do that is through claims. So one claim on one episode was qualifying within this audit. We reached out to EQIP entities who did not reach these thresholds and asked them to edit their care partner list so that way they could make it. These edits were due last Friday and everyone complied. So we really appreciate your efforts here to kind of trim up those care partner lists and ensure everyone included was viable within the interventions. We are going to rerun the audit for those entities and work one-on-one if there are any kind of last minute changes that are necessary. Though we, think that everyone went through this process in a faithful manner and kind of really thought about who the interventions were touching. So we appreciate that. We'll follow up with those entities next week on the results of the second audit. So that way you can be assured that you are all set by participation standards. If your EQIP entity was not contacted, you're in the clear and your threshold of 75% touching a baseline episode was met. Additionally, results from the PECOS vetting from CMS will be available in your EAP in that care partner dashboard that you all have next Monday. So we are going to pipe back the results of the first round of CMS vetting, which is just checking if you're enrolled in PECOS and kind of up to date with all of those details. If you have care partners that did not pass PECOS screening, we will not generate a contract for them. They are not going to be permitted to participate in year one. However, it's not all bad news there. PECOS is very simple to update and correct. We have a checklist on our website with kind of things to look at and contact CMS through. So if you did not pass PECOS vetting and screening for this first performance year, the second performance year is definitely not precluded. There are two other CMS vetting processes, the one being program integrity, making sure that there are no fraud allegations with CMS, those sorts of things, and law enforcement vetting. These are still ongoing. They take a little bit longer. We wanted to get the PECOS results out to you all first, since those are typically what snags most providers. We do not think that the impact will be very large from these program integrity and law enforcement vetting processes. So we'll pipe that information back again through EQIP, but we'll let you all know when those results come in. We also will be sending out the care partner arrangements to the lead care partners and administrative proxies starting on November 1st. So just about over a week from now. We actually are going to be batching your contracts or care partner arrangements for each EQIP entity and sending it only to those lead care partners and administrative proxies. This comes from some very helpful feedback from you all. Kind of indicating you would like to manage the communication and dissemination throughout your practices. And then also saves us from getting 2,400 email bounce backs when we try to individually contact physicians. So we will be batching those out starting on November 1st. The email will come from the University of Maryland Medical System, very simple address, equip@umm.edu. This is also where the contracts should be returned when they are signed. But it's to the University of Maryland directly. Additionally, the contracts are going to be pre-filled and standardized across the state. So I am participating in this EQIP entity. These are our episodes, and we are going to be performing these types of interventions. We will not allow any changes. This care partner arrangement went live with our last EQIP subgroup meeting and has been posted on our website since then. We haven't had any significant feedback to the content of the care partner arrangement, and so we consider it to be vetted by our stakeholders here. If you have any questions though on the contract or policy that's included within it, please again reach out to that crisp inbox. We are happy to chat through any questions, and considerations that your physicians might have surrounding this care partner arrangement. All of these have to be signed and returned by December 31st, 2021. No exceptions will be made. It's, we've got 2 months to do this contracting process and get these returned. It's a simple digital signature. So we're hoping that folks can get these turned around within the next 8 weeks or so.
Do we have
okay,
a copy?
there,
When will because our corporate counsel is going to want to review that. And I know 8 weeks sounds like a long time, but when you get counsel involved, time can go by very quickly. So when do we get at least the even if we just get the boilerplate, if we can get a copy of a blank boilerplate, kind of what the contract's going to look like, she can start reviewing that for us.
Yeah, absolutely. It's available on our website right now on the EQIP webpage. I'm happy to send you a copy though directly, Dr. Grasso.
Great, thank you.
Are there any other questions on enrollment next steps? I know many of you have been reaching out to Jessica, and she's doing a great job of kind of managing any one-off requests and comments. So please keep doing that, and we'll keep working with you as well through that EQIP inbox. So moving on to the fun stuff. As a reminder, these are the episodes that we brought on for performance year 1. They were mainly procedural and acute in those 3 sort of buckets around cardiology, gastroenterology, general surgery, orthopedics, and neurosurgery. These are only 15 of the 97 Prometheus episodes that we could potentially bring on to the program. So this is really exciting for us as policymakers. We have this off-the-shelf resource that we can add to the list with. So we want to kind of think through how to do that process thoughtfully with you all. So in terms of the development process, this fall and winter, we're really going to be assessing where there is stakeholder interest into these episodes. So we want to see, who's interested in a cataract episode versus a mastectomy episode, and really ensure that if we bring on certain episodes, there will be robust participation, or at least interest in participation. We will also develop an analytic plan for the episodes this fall and winter. Anything that we bring on, we want to make sure the dollars and cents work for the state and help us under the total cost of care model So we will be doing ad hoc analyses and ensuring that it fits into the policy in the ideal manner. This winter, we will work on, or winter 2022, so early next year, we'll work on finalizing the policy design and ensuring that CMMI is approving of these new episodes. They are ultimately the party that gets to decide yes or no what we include in the program. So any new policy changes or additions will need to go through them, but we'll work on that early next year and have some indication by the spring. Once we have that indication from CMS, we will move towards recruitment episode education. So next spring, we'll really work on ensuring, if we bring on that cataract episode, that all of our ophthalmologists in the state know about the opportunity and have the opportunity to, learn about the episodes and ask questions about the program. July of next year, we will open enrollment for new care partners and EQIP entities. So we will start this process all over again next July. There will be the same July to September timeframe to get everything organized and in for CMS vetting. And we'll, kind of do this whole thing again. And then January 1st of 2023 is when performance year 2 will start. So you'll, within that July to September period, be able to change your care partner list, add new care partners, edit episodes, really kind of tweak anything about your performance, and then bring on any new performance year 2 episodes. So this is the high level process. We're going to keep building this out as we move along. But I want to see if there are any questions before I move on from here.
Just a quick question. What will the baseline year be for 2022?
Great question. For 2023, do you mean?
Correct. Sorry.
Yeah. Yes. Well, it will be 2022. So moving forward, the baseline will be the year prior to the performance year. So this is the only year that will have that 2019 baseline, mainly because we had to skip a lot of the utilization aberrations from COVID-19. Is why we use 2019. And then moving forward, you will get the year prior, but there will still be that fixed baseline for the first 3 years of the program. So we'll keep your baseline at 2022 for the first 3 years of your participation if you join in performance year 2.
And there will also be an escalator, right? Based on the EQIP, the way we built it.
Yes, correct.
So we have a question from Nikki in the chat. Who should we connect with if we have thoughts about future episodes? And Jessica just responded with the EQIP at CRISP Health. The one other point I'd like to make on that, other than emailing EQIP at CRISP Health, MedChi is willing to set up meetings with specialties and work with specialty societies. If you think there's a level of interest, we're happy to help host it or help put it together. The other point I would make is that looking down this list, we obviously are heavy on the specialties that are involved in the current episodes. And we have a couple people, I know I saw like Dr. Safferman who's a radiologist and a couple of people who are in other specialties, but some of the specialties that we would be talking about or considering are not on this call. So I would just ask folks to reach out to their physician colleagues and see if there's level of interest. And we're happy to do outreach in a collaborative effort like we did with regards to the orthopedic, neurosurgeon, GI, and cardiologist last time. I think that
thanks.
Philly
go ahead.
that one, Maddie.
Yeah, no, I think those were excellent last time, Jean. So I'm looking forward to recruitment round 2 with you next spring.
But I also think we need to focus on kind of if we have areas or codes where you think there might be interest, we can, have a discussion and bring people together and make sure we have a level of interest before we do too much work. And I just would encourage everybody on the call, if they know somebody who thinks they might be interested or they think that there's a specialty that we should really look at, we're happy to do a little groundwork on our end.
Yep. Absolutely. Yeah. Please, if there's interest, reach out now and sooner rather than later. Okay, so getting into a high level framework of what makes an ideal episode within EQIP. As I mentioned, there are 97 available, but we have some additional parameters that make them interesting to us as a state. So the first is fairly obvious. We want to look at episodes that are high cost of care and high volume within the state. We want this to have an impact to our total cost of care model and our tests underneath it. We want to drive results with this, and we want to ensure that this impacts a bulk of Medicare fee-for-service spending. We also, though, want to look at episodes that have cost or quality variance across the state or other disparities in care. Is there a certain population that could greatly benefit from getting more value-based payment incentives? Or is there a variance that is higher across the state in a certain episode category that represents an opportunity to kind of, look at those outliers and see where there's opportunity for improvement? We also want to focus on any additions that are procedural or acute episodes. Our first year episodes were designed off of these very time-limited, specified windowed episodes. There are other options within the Prometheus episode suite that we'll talk about, but anything procedural or acute will be very easy for us to add on to the current EQIP methodology without any change. So that's where we're first line going to focus. Additionally, we want to look where there's opportunity for cost and quality improvements. So we'll look at which episodes have a high proportion of their costs that it's coming from potentially avoidable complications and potentially avoidable episode costs. So again, looking at where there's opportunity for providers to really drive change and results. We also, as always, want to ensure that we have alignment with the other episodes of CARE program. Care First has expanded their episode offering. So we want to look where that commercial alignment is available. So again, we keep that multi-payer alignment that has been, I think, a great boon to EQIP's kind of success and definitely a priority that we've heard loud and clear from CMMI and a priority of ours as an all-payer state. These next two are a little bit harder to get numbers around, but still very important. We want to ensure that there's stakeholder interest, as Jean mentioned. Please reach out if there is. I'll also have my email address up if they're at the end, if there are specific comments that people want to submit on these episodes. But we really want to ensure that this is a stakeholder driven process as it has been from the start, and ensure that there's interest in participating in these episodes if we develop them and bring them online. And then finally, we want to look at episodes that are exclusive to EQIP. So there's not a ton of overlap with other participation opportunities in the state. It's not significantly sharing a population with other programs and value-based payment structures within the state. I think with the Prometheus episode suite, this is a little bit easier for us, but again, something to consider so that way we don't have to work through significant overlap issues in future years. So first, looking at the potential acute year two episodes. I'll first start this with a caveat that I'm not a physician, so I'm happy to discuss any details or questions you might have around these, but I do not have the episode definitions memorized, so I can't answer specifically what ICD-10 or CPT codes trigger these and what's included versus not, though I can give you that detail. So if you're interested, please reach out. Looking at potential additions for acute episodes, as a reminder, these are the inpatient episodes that are triggered off of an inpatient stay with a confirming diagnosis for the disease or acute event of interest. Right now, we have two online, the hip fracture episode and the acute myocardial infarction episode. So it works with the EQIP methodology. There are 4 others within Prometheus: diverticulitis, pneumonia, stroke, and upper respiratory infection, all of potential interest for different reasons. So if we look at the high volume episodes, in the Medicare population, pneumonia, stroke, upper respiratory infections, those are very high volume episodes for the Medicare population. Diverticulitis is not as high volume, but if you see in that second column, the variance is very high here. So that means that there's high variability throughout the state in how the costs shake out within the episodes. compared to the stroke, it's much more variance. And so I would say opportunity for us to get to a better average here. Additionally, though, stroke is still high cost. So again, it's both high cost and high volume, meaning that's over $10,000 an episode. So some good opportunity to create savings and quality improvement there. When we look at costs that are due to potentially avoidable complications, again, diverticulitis is of interest here in that it has a large proportion of its costs due to potentially avoidable complications or opportunities for care improvement. However, all of these acute episodes really do have significant opportunity. We consider potentially avoidable episode costs to be where there is room to improve and the costs that should be most greatly impacted by EQIP. In terms of commercial alignment, CareFirst has started offering contracts for diverticulitis. They have not for these other 3 episodes, though that would not preclude us. So, a couple different enticing data points to add to the calculation of what might be an episode we want to bring on, though I think all 4 of these are potential considerations for year 2. Are there questions? And I'll pause for questions on each of these and as we work through.
Yeah, Maddie, I have a question.
Mm-hmm.
It's easy to understand how the procedure-based episodes are triggered, but for pneumonia, how is that triggered? And then what provider is it attributed to?
Great question. So the first answer is it's triggered off of an inpatient stay with a confirming diagnosis for pneumonia. So it'll be off of that first inpatient stay. So for attribution, what we've seen is it's a mix. So for our AMI episodes, we have a mix of cardiologists and hospitalists triggering those heart attack episodes. So that would be something that we'd want to look at in the data with you all. I think actually for the first year of EQIP, we did include a significant number of hospitalists who were triggering acute episodes and saw that as a good opportunity to, engage those contracted hospitalist groups within, more value-based payment programs. So we were excited by that we could have a mix of both the specialists and then, contracted hospitalists or even in-house. So that's another kind of angle of interest for these acute episodes.
Hey, Maddie.
Mm-hmm.
Hey, this is Bob Linton from Howard County. Regarding the diverticulitis, it's not listed as a high volume or high cost diagnosis, but did you include it because the variance is so high that there's opportunity in that regard? And are there other diagnoses that you came across like this?
Great question. So short answer, yes. This is included because there's that large variance throughout the state and large amount of potentially avoidable episode costs. So while it's not episodes that typically go over $10,000 an episode, that doesn't preclude it from being of interest in that, there is opportunity for those providers that do treat that disease course. So in terms of other kind of diseases or diagnoses that would fit this, the answer here is no. This is what's available within Prometheus. So we kind of off the shelf had their episode, this is run off of our Maryland Medicare data, but they only have episodes in these 4 acute areas in addition to what we've looked at.
Okay, thank you.
I like the fact, Maddie, on here that you talk about commercial alignment, and obviously you're talking about the CareFirst there. Are we in discussions with Medicaid about aligning EQIP with Medicaid, and do we see that happening in year 2 as well?
Yeah, so it's definitely something that we are exploring with them right now. We've had a couple of conversations. I think there are competing priorities, Jean, with alignment with MDPCP as well. So I'll cover there for my Medicaid colleagues a little bit, and that, for year 2, it might be a little quick to get approvals necessary for alignment, but we are definitely in talks with them weekly on this topic to ensure that we have alignment there and we get this into that population. We've also talked with some managed care insurers for the Medicaid population that have some interest in aligning as well. So that would be a little bit quicker.
The only point I'd make, EQIP should be a little easier to align than Maryland primary care without getting in the Maryland primary care rabbit hole.
Yeah.
So I mean, you know, it seems to me that we're only sharing upside risk. So it's not like there's not the economic pressure. And it just seems to me that it shouldn't be that complicated to get it up and running anyway.
Yeah.
And I'll just jump in here to underscore Maddie's point. We have been working closely with the Medicaid team. I think, again, there's a specific interest, particularly from the CMMI team, to start, sort of a multi-payer alignment strategy with Medicaid. And the initial focus is on NDPCP. But we've also been spending time with them to share, for example, information on Prometheus, so that they can start to understand where there are opportunities, what that tool can do to help them in designing similar programs to EQIP. And so from a Medicaid standpoint, certainly we're already thinking about multi-payer alignment. But then we're also looking at other commercial payers as well. So we have started conversations with other payers in the marketplace to also identify whether or not there are opportunities to align. So this is something that's top of mind for us, and we'll continue to keep this group updated as we make progress.
But I mean, not to belabor the point, but just given with the fact that you don't have the economic issues on the money side, and that frankly we have the duals issue, which is somewhat unmanaged, that might be a nice place to start with EQIP. It just seems to me that EQIP might be easier to align quickly, and that we should be able to figure it out. So and maybe the first alignment starts with care first, and I understand that, but it just seems to me that we should be able to figure it out for Medicaid. So enough said, I've made my pitch.
Thanks, Jean, and thanks, Tequila. Yeah, we're interested in bringing on as many aligned payers as possible. So we'll definitely keep this group apprised and have further conversation as we move along there. Okay. So those are the acute episodes that are available within Prometheus. Looking at procedural episodes, there are a number that are also available within the Prometheus episode suite. So I won't go down the list throughout. You can read here. However, I do want to, again, note that there are different reasons why each of these might be of interest. If you see here, we've got a number of high cost procedures, bariatric surgery, hysterectomies, gallbladder surgeries, lung resections, mastectomies, prostatectomies, getting a little bit closer to that cancer care, but still staying very procedural in that there's a time limited, kind of scope for when these procedures have impact on cost. However, there are other episodes of interest based off of the variance and volumes that exist. So cataract surgery is an extraordinarily high volume procedure within the Medicare population. While it tends to be lower cost, this high volume means that there would be greater population impact for Medicare beneficiaries. Looking at variance, there's less so in these procedures. There's more standardized routes of care. I saw that our colleague at CMI, Adam, mentioned that there's, where is there heterogeneity in the care pathway versus none? I would say with these procedures, there's probably less so, and we see that here with the variance. With potentially avoidable episode costs, though, there's other opportunity in that, our gallbladder surgeries have about 8% of their costs coming from potentially avoidable episode complications. Same with the transurethral resections. It goes lower based off of each episode, but again, this is what would be the opportunity for cost and quality improvement in the program. And this is also where CareFirst has focused a bulk of their episode expansion for contracting as well. A number of these episodes they do offer within their contracts, and we're hoping that other payers will as well. So bariatric surgery, cataract surgery, hysterectomies, mastectomies, prostatectomies, and transurethral resection prostate would get us that multi-pair alignment for EQIP within these. So I'll pause again and see if there are questions on the procedural episodes of interest. Again, I think the biggest differentiator here for what we do or do not bring on would be stakeholder interest. You know, I think with the commercial alignment that we have and the relative high cost for each of these episodes, for most of these episodes, we would consider them to be enticing for the program. So we'd want to really hear from stakeholders here as to what would be most of interest.
Hey, this is Jim. Just a kind of a quick question. I'm sitting there thinking about the previous slide, and as we looked at as I'm looking at the list that we are presently working with, I mean, even acute MI and the hip and pelvis fracture, even though they're acute episodes, they're procedurally oriented. I mean, both of those diagnoses as they come in are in all likelihood going to get some sort of procedure or around that. And in that, really, as we were getting into this program and recruiting practices, this is very much the orientation that I think a lot of us had around this. And I can certainly see it in the slide you have up here, but the previous slide seems very different. You're talking about diagnoses that, you know, while there may be an attributed physician, you know, on the inpatient side, there's multiple steps in the process and care of that patient. And there may be multiple handoffs where you would not really expect that from the procedure oriented diagnoses. So I'm trying, I realize you guys were looking at it from the point of view of high volume and high price and variance, but was there any thought around that when you were looking at those 4 acute diagnoses as far as including them in here? Because like I said, they seem very different from the pattern that we have and the way that we were approaching, or it seemed like we were approaching this being oriented towards really, you know, a proceduralist of some sort.
Yeah, I think that's a good observation, Jim. I think the difference that I would add is the acute episodes are really centered around those inpatient course of stay. So it's less so focused on, you know, the acute event that has procedures connected to it. For the first year, the reason that we brought those 2 on actually is because we thought that they would, you know, more closely align with the specialties that already had procedures involved. So that actually is the approach that we took, as opposed to thinking about it from a procedure mindset. And I would, you know, just add that, you know, the acute episodes are really focused around that inpatient course of stay. So it's a little bit different. You know, I think that's a good consideration when we're looking at bringing on these additional acute episodes. You know, are they moving away from that procedural type of service with regards to inpatient care? But we can definitely look at additionally, you know, who is triggering these, and then also what types of procedures and costs are typically getting included, so that way we can get a sense of, you know, how similar or dissimilar they are from our current 2 acute episodes.
So we have
I think the big thing is going to be for us to understand really how you said it was a mix before. How do you attribute this to an individual physician? Is this, I mean, because we have to recruit physicians into this program. Right. So, you know, I can't go to the neurologists for the stroke pay. Like I would need a lot more to understand how you plan to attribute these to an individual physician. And if it's hospitalist, fine. But that's who cares for our patients inpatient, not community physicians.
Yeah, absolutely. And so what we can do on that front, you know, and I think we went about it in the first round as well. We can, you know, go ahead and get you that triggering information. You know, it's triggered in more detail there as well. So it's the rendering physician on an inpatient claim with these certain ICD-10 codes. So also you all can, you know, kind of dig through and kind of start to sort through. Again, also any NPIs of interest that you would have, you know, is it my neurologist group that's triggering these based off of the way we submit claims, or is it my hospitalist group? We can go through that process again, you know, with that kind of opportunity analysis that we did the first round. So I think there are ways to get at that question, Cindy, and we're happy to help kind of unpack that over the next couple of months. But that's helpful to hear that would be, you know, a large consideration for how you kind of approach this.
So maybe you guys can get us the list of triggering criteria for the episodes that there's excitement at the HSCRC level for, and I can send it out to this list, and we can maybe send it out to some of the doctors who we believe their specialties might be involved, and see what level of interest there is, just to garner some interest and get some answers, because I think those are really good questions, Cindy. There's a couple questions in the chat. How many episodes do you consider bringing on for the upcoming year? Maddie, do you want to tackle that?
Yeah, so we don't short answer is we don't have a set number that we want to bring on. So we want to bring on episodes that have interest in the program, have stakeholder interest for the program, but then also makes sense from an analytic perspective. So as I mentioned on that process slide, we are gonna kind of build out our analytics plan based off of initial stakeholder feedback here, and then you know, go through that process alongside that stakeholder engagement. So right now there's no set number that we will or won't do. It's mostly, you know, what comes out at the end is looking like a winner. I don't think that we have any hesitation on bringing on, you know, another bulk of episodes if people will participate in them.
So if I was summarizing the three factors, it's interest, alignment with the model, and then bandwidth, right? And really those three factors are going to determine it.
Yeah, I think that's a good summary.
Okay, and then the next question is from Jamie Williams. How does the PY2 gallbladder surgery differ from the gallbladder surgery captured in year one?
Yeah, so it's erroneously included there, so my apologies. We do have gallbladder surgery in year one. I'm just going back there to confirm it for you all.
Good catch.
Yes, thank you. Are there any other comments on these procedural episodes? I know that's a little confusing on how they work with the acute episodes, so I think that's helpful feedback for us to unpack further. But I want to, you know, specifically highlight the procedures here as well.
I'm interested in how breast biopsy even made that list. It is not high cost or high volume. It has a moderate variance. There's really no avoidable cost, and it's not commercially aligned. What would we hope to gain by including that?
Cindy, you might have identified the first that we might not be doing. So it was included because it's a procedural episode in Prometheus. So we wanted to give it as an option. You know, it does go alongside if we were to bring on maybe mastectomies, you know, bring on some opportunity for those that are treating breast cancer. But you're correct in that there's not a ton of variance for us to get at. There's also not a ton of volume or cost. So
we're doing well on that in the state, but that we can take that away from it. We do quite well with that. Okay, very good. Okay, so moving on, there are some other episodes available in Prometheus. They actually have the category of other. And so as you can see here, they're other for a couple of different reasons, you know, mainly that they're focused around cancers or longer disease courses, such as hepatitis C. There's also one around preventative care. But again, we have a primary care program kind of getting at those volumes as well. We wanted to still present them because they are available within the 97 episodes and see if there's interest. I think for the cancer episodes, we would have to really dig into the episode methodology and ensure we were okay with what was included in the definitions and we understood how that was working with our Medicare Parts A and B. However, there's a lot of high cost included within these cancer episodes. And in that way, you know, it might be of interest for the state to start thinking about some episodes around cancer care. When we look at variants, though, the two opportunities are in our non-high cost episodes. So the hepatitis C episode and gynecological cancers. There's a lot of variance in how these two courses are treated throughout the state. And so that would be of interest to us. When we look at additionally potentially avoidable episode costs, you know, some of the cancer care has less so due to complications, but
some still has a significant amount of opportunity to impact the quality of care. So, the gynecological cancers, colon cancer, rectal cancer, lung cancer are all really high complication
One thing I would really help
episode costs.
me.
So I will mention, that there is not currently a commercial opportunity to participate in these episodes. These would be unique to EQIP. But maybe we could work with our partners to think through their methodologies and if they would want to bring them online. So definitely not out of the picture for us in terms of, there's cost opportunity and a specific population that we could improve care for. Are there questions here, comments, concerns?
I would just say, again, I think back to Cindy's earlier point, I think the attribution triggering mechanisms, if you can get those to us so we can start figuring out, would be helpful. Some of these might be a little bit easier, but I think it's still just useful for us to figure out. It'll be easier for us to determine levels of interest that way.
Yeah, absolutely. I think that would be very helpful. So we understand who and where these episodes are going to. Okay, so these are all the sort of off-the-shelf episode definitions that we do think will work with EQIP's current methodology. We don't have a specific way that we would change the current methodologies. There might be certain financial tweaks that we need to make to include each of these. But again, if there's stakeholder interest, we feel comfortable with the attribution, we feel comfortable with the costs and the definitions of these episodes. I think they would all align well with what we've done in performance year 2 of EQIP. So we wanted to give you some data points as you're thinking through with your practices and other stakeholders for what episodes might be of interest to you. But this is kind of the gamut for what's available to align easily with year 1. However, there are a number of episodes that are of significant interest to us at the state that are surrounding chronic episodes or chronic diseases. Prometheus also has episodes around different chronic conditions. We think that these could really help complement existing acute and procedural episodes to enhance patient care and outcomes. If we were to implement chronic episodes, say around osteoarthritis, not only would you be performing the knee surgery or have specialists, their practice physicians could then be focusing on management of that osteoarthritis long term. We also think that chronic episodes should be implemented to ensure that creating episodic incentives around procedures does not erroneously grow the volume of procedures. We don't want to create kind of a perverse incentive to increase the number of knee surgeries that you are doing if the osteoarthritis could be managed. I'm picking on that one because there's a very clear linkage to an episode that we already have included. So it's no true aim at those episode types. However, we really would need to analytically unpack how chronic episodes work with the current methodology and financial structure under EQIP. These are relatively low cost episodes compared to the procedural and acute episodes that they would fall underneath them. Again, that going back to that osteoarthritis example, underneath that episode, any knee surgery or joint surgeries would be included in the management of that osteoarthritis episode. Additionally, these episodes do not have a set post-trigger duration. Determining the cut point and other parameters around how we include it in our methodology might be arbitrary because, again, you don't cure someone of their diabetes. It's an ongoing management of that chronic disease and assurance that it doesn't, lead to long-term increased costs or avoidable and acute events. So getting into what episodes would be available, there are quite a number and a number that align with some state priorities. There's a lot here around behavioral health and mental health. The state has a lot going on to integrate behavioral and mental health more into our system so that we can improve the outcomes for these specific patient populations and then also improve our performance under the total cost of care model agreement. So these would be of interest to us. There are a number of chronic diseases such as COPD, Crohn's, ulcerative colitis, again, that I think specialists manage a lot of the care for. So it would be of interest for EQIP because, again, you have specialists who are really the quarterbacks of the care decisions and long-term management here. And then we also have a number of diseases that really cross over with our SIHIS goals, or a statewide integrated health improvement strategy. That would be of significant interest to us at the state. Those being hypertension and diabetes would really, help with that alignment piece and increase our performance, both under SIHIS, but again, under the model as a whole. So these are the episodes that are available. Again, we determine the length of the episodes when we cut off for measurement, that sort of thing. And then the Prometheus episode definition gets us at that relevant cost piece, what costs are actually included in the episodes. So additional considerations for adding chronic episodes and some items that we'll work through over the next couple of months. Again, these episodes tend to be low cost. So the procedure and acute episodes would actually fall underneath these chronic episodes, but these would also be things that you would want to avoid to ensure that the target price is met. So for example, again, if an osteoarthritis episode has an average of about $1,000, a knee replacement underneath it would be $16,000 and would likely erode the performance of that $1,000 target price episode. So the traditional structure of here's a target price, beat it, would really be at risk at smaller volumes at the provider level if you had one acute event or one procedural event. Additionally, the incentive to participate for participants is higher in those high cost procedural episodes because there's more opportunity to create savings and also more opportunity to earn off of those savings. However, chronic episodes, we feel at the state have the best incentive to impact upstream and really work on that preventative care for patients to really avoid those high cost procedures and acute events. So we have a little bit, a little bit of incongruity there. And so we want to ensure that by adding chronic episodes, we align with the incentives we've already placed for procedural and acute events, but then also enhance it in that we get more specialists to focus on preventative upstream care. So some options for methodology inclusion, and this is very high level, but things that we'll be looking at over the next couple of months is, looking at a performance-based incentive structure similar to what we've done with the target prices here, though we would probably have to make some tweaks to account for that dynamic that I mentioned, where these are very low cost episodes and could have high cost acute events impact your performance. But that's an option for us to consider some changes to the methodology for inclusion of these episodes. We also could look at creating adjustments to procedural and acute episode reconciliations or performance based off of your chronic episode performance. So, if episodes, if we have poor performance on your chronic episodes, we could adjust or increase your procedural acute episode reconciliation. So sort of a backstop to ensure that we have still good prevention and management long-term on these chronic conditions. Additionally, we could also just move forward and think about attributing patient populations to specialists. We could, move full forward and think about specialist medical homes and, thinking through what diseases are really managed by these specialists and should be have a completely different financial structure created around them. So those are three options and some areas that we'll be exploring very high level, but wanted to see if there's any initial feedback on what would be of interest here and chat through that.
So Maddie, it's Dr. Grasso again. And EQIP is basically built on a BPCI model, which is not applicable to chronic diseases. The way to go is probably the last bullet point, the attribution of patient populations. What's been done around the country in a couple places is with like a Medicare Advantage program through a United or some other private payer, is basically the specialists take a per member per year kind of payment, almost a capitated payment, and they go at full risk for that. That's what CAO, that's our ultimate goal with our commercial payers, is to go to full risk based on capitated payments, based on per member per year. And I think that's the model, that's the only model that's really going to work for chronic. And it also will roll up the procedural as well, because that's included in it. So it will disincentivize overuse. Now, on the other hand, you also don't want to, incentivize disuse too. If somebody really needs surgery, you want them to be able to get the surgery. So, there's no perfect program, but we think the full risk bundled capitated payment is the way to go.
Great, that's very helpful. And I've definitely been eyeing those different models, Dr. Grasso. I think the one caveat and tricky thing that we'll have to get around here with an EQIP structure is that we're not directly adjusting the Medicare fee schedule or payments that you all receive. You receive your payments normally under the Medicare fee schedule, and we at this time wouldn't have that capability to include an EQIP at all without kind of developing it through a different mechanism with CMS. So I agree that that's probably the best way forward, though want to think through if there are other options on the table without that capability to directly adjust payments prospectively.
Having MDPCP too, what's going on in my head is, we look at diabetes, COPD, CHF on that list. Is there some way to use the technology of Prometheus and the data from, the data power of that program in that program for those diagnosed, instead of trying to shoehorn that primary care stuff into EQIP? Is there some way to use this technology to support MDPCP? I have no idea. It's just a thought rolling around in my head.
Yeah, I think that's a good thought. I don't know if I can speak for my MDPCP colleagues or CMS on that front, but I think that's something for us as a state to consider. Definitely.
Yeah, they'll be shooting me sometime soon. Yeah.
No, they're all good thoughts. I appreciate them. So yeah, no, I think that's a good idea, Cindy, for us to kind of chat with them. We have these insights right now. We can tell you how we're doing on, management of schizophrenia as a state. That sort of thing. So there's definitely the data and the insights and the technology are available to us. So we can think through, if they don't fit in EQIP, where else could we potentially utilize them? Okay. So that's just a quick high-level overview. I think 2 very helpful points. If you have any additional thoughts, please reach out to us. I think we as a state are excited about thinking through a specialist medical home. Our capabilities under EQIP might not be the right spot, but we definitely want to see if we can fit that in here again, because we want to think through whole incentives and really get towards that total cost of care side of things. Okay, and so for the last category of episodes that we would consider adding in year 2, we, from the start of EQIP, have intended to develop emergency department episodes for a couple of reasons. But however, because we went through the care redesign program for this and the Prometheus episode suite, we weren't able to include them in year 1. However, we do plan to develop them alongside Change Healthcare, exclusive to Maryland. So a really exciting opportunity for us to lead as a state. The reason that we want to explore these is that Maryland emergency physicians largely remain on fee-for-service contracts. So we want to think through creating direct alignment of those physician group incentives with the goals of our model and what hospitals are already doing under their global budgets to reduce preventable admissions and readmissions and improve their community health. So we really think that this is a point of alignment that we can improve, given that most of our Maryland emergency physician contracts are still on that old chassis of fee-for-service. Our plan is to develop these episodes for performance year 2. Research does demonstrate that emergency physicians actually can have a large impact on cost and quality after an emergency department visit has already occurred. Connection to that community care post-emergency department visit can also prevent future utilization due to complications or unresolved medical issues, or just you only know the emergency department is your access to healthcare. Additionally, emergency physicians are often the common decision maker about who gets admitted to the hospital. And this has considerable total cost of care and outcome implications for acute hospitalizations and post-acute care, but also it has significant, the decision to admit, as I'm sure many of the hospital folks on here know, has considerable variation in, time of day. Is the shift ending? What's the disease course? What's the capacity? There are a lot of different things that I think hospitals have been thinking through, but again, because our physicians still remain on this fee-for-service incentive, they just can't participate in because it means erosion of their revenues and margins. So we are hoping to develop 2 episodes with Change Healthcare and with you all as stakeholders around efficient admission practices for specific conditions. So the concept here would be to allow emergency physicians to take on some accountability for diagnoses where there's a documented variation in the decision to admit, and where there are clinical decision rules or best practices that could be applied to accurately identify patients who would benefit from hospital admission. So really getting at those patients who would be admitted to the hospital and ensuring that there's a smooth course of care. The other episode that we would be interested in is high frequency emergency department use. So frequent users of emergency departments, they disproportionately consume emergency care as well as other sources of care. This population includes patients with high prevalence of chronic illness, mental health conditions, and it also presents an important opportunity for us as a state to work on health equity. We don't want people to be utilizing the emergency department in high use, because that's not the best place for them to receive their healthcare ongoing. It's not the most connected healthcare, and it's not community-based care that can really help them tackle their health and mental health issues. Frequent ED users also have a higher mortality. It's proven in research, and are at higher risk of adverse events. So research does suggest here that interventions to address their needs of these high utilizers may serve, kind of a threefold goal of reducing our emergency department visits further, shifting care to the primary care setting, and then overall reducing costs long-term. So we think that EQIP can help provide these incentives for emergency physicians. They would be expected to identify patients as high utilizers and work with case management and longitudinal care partners to address the unmet needs of this population. So we're really excited about kind of getting at this frequent high utilizer emergency department care as well. So I'll go to the next slide and we can kind of chat about this after that. So here's just some basic sketching of what we would think about in terms of a trigger that we need to look at, and some exclusions, and then the specific conditions that we would be looking at for both of these. It's listed under high frequency ED use, but it should be here for both. I think there's some argument that some of the high frequency ED use shouldn't be condition specific, and maybe only efficient admissions should be. But again, something for us to further flesh out with stakeholders over the next couple of months. The length of these episodes is much smaller. So again, emergency care is very time limited in that one touch, hopefully. But again, there is some accountability that could be driven throughout the next 14 days, 30 days. If someone doesn't make it to that follow-up primary care visit and has an avoidable acute event, that handoff probably should have come from the emergency department, those sorts of considerations. Okay, so I will keep moving. So further development here, we have a couple of key episode components. That is not as much detail here as what we typically have for our Prometheus episodes. So we really need to build. We are going to have to build out the relevant procedure and diagnosis codes and lists and exclusions to what will be included. The business rules for overlapping episodes, and whether or not we exclude certain patient populations, what the financial methodology would look like, how closely is it to what we've already developed for performance year 1? Do we need to tweak it alongside some other tweaks we might make for performance year 2? How we would identify potentially avoidable complications and opportunity. All of this would be on the state to define. And then again, we would want that stakeholder and system interest. So we'd want to ensure that this is, of interest for us to bring on these incentives for emergency physicians. We are going to work with Change Healthcare to integrate this into the Prometheus construct. So there is an industry advisory board that will help us with this definition. There's a number of great clinical minds on there, but then also people who have been running episode programs for quite some time throughout the country. So a lot of experience for us to really tap into there. And then we also have some emergency physician stakeholders that will help us to refine and work on the definition. So if anyone here is interested in being a part of this process, please reach out to me and let me know. We're really hoping to get as many minds at the table so that way we get the best product possible at the end. So our timeline for completion here is going to be March of 2022. So we've got a lot of work to do in just a short number of months, but we're excited about potentially bringing on this opportunity as a state. Are there comments, thoughts, questions here on the emergency department episodes?
Hi, my name is Mike Silverman. A couple of us from the Maryland chapter of the American College of Emergency Physicians are on. Thank you for outlining this. We've been working on this for probably 9 months to a year and have had a lot of good conversations behind the scenes, and we'll continue to have more conversations. We're interested in having a high stakeholder buy-in. And I think we've had some evolution since this was first presented. But thank you for giving us this, and certainly getting things with Change Healthcare into Prometheus will be very useful. But more to come, and we'll continue to be in touch.
Great, yeah. We're looking forward to working with you guys on this, and I think it'll be a great benefit to EQIP.
And Dr. Silverman, I saw Dr. Linton on the call. I think he said something earlier as well. There has been a high level of interest from emergency room doctors in this space. So if we get the change made in by change in Prometheus, can we get it in as a code for next year, or is that for the next year? Are we really kind of on a tight timeline here?
Our intent is to bring it on for year 2. So, and it could mean that we slip from our timeline of March of 2022 a little bit. But we're really hoping to bring this on for performance year 2 opportunity.
Because that is a high priority. We've had a lot of physician interest.
Yes, absolutely. Okay, so I had some discussion questions up, but I think, people have really provided some good input, on what would be the most interesting or least interesting in terms of an episode. Considerations for the financial model, as opportunities grow, we should think about collectively what outcomes we should further incorporate into the program. Should we have an eye on total cost of care in addition to the relevant cost? Should we think about quality and utilization standards? Are there other pieces that would be of interest to include, so that way the program has maximized impact in the state? So just some thoughts, if there are any additional questions and comments to pique those, but otherwise I really appreciate all of the input that's been given thus far.
Yeah, and I just want to reiterate, MedChi, and I think I feel comfortable speaking for Maddie on this, the HSCRC, we're very happy to do one-off meetings or meetings with a group of physicians or a specialty society or a hospital unit that is considering or wants to talk about a certain set of codes. And again, like with the emergency room doctors, when they came to us, actually maybe more than a year ago, it was clear that it wasn't a Prometheus code. I don't even know that is a complication that obviously adds another level of complexity to it. But if it's in Prometheus, then we can really have a discussion, and there's a real possibility we can get something done. But we're very willing to do those extra that work and help you out offline. So we would just urge you to really think about what you might want to do and come back, and we're happy to set up calls and see if we can't get other people engaged. So if you're a group at a hospital and you really want to do diverticulosis, well, then maybe we can go and find some other groups that want to do it as well, so we can pitch it as one of the episodes we should add on. And please reach out to us. We're happy to do the work.
Yep, thanks, Jean. Couldn't have said it better. So in terms of next steps, as Jean mentioned at the outset, the November meeting is canceled. We will have a meeting on December 10th. It's kind of an ad hoc. We had been trying to keep this third Friday cadence, though that gets harder in the month of November and December due to some very big holidays. We will use this meeting to discuss the quality benchmarks, which should be published by them and by then in EQIP and other performance year 1 insights. Though again, please reach out to us if you have specific data questions to Dr. Grosso's comments in the earlier part of this meeting. We definitely have further insight that we can provide. We just haven't had the time to build it all out in EQIP and get everyone enrolled and tell everyone about the program, et cetera. So we will also, after we get through this December meeting, set a new schedule for 2022 dates. I do want to keep it on the third Friday of each month, so it's easy for everyone to remember. But we'll let you know about that schedule in the next couple of weeks. All of the care partner arrangements will be sent November 1st to your administrative proxies and lead care partners for each EQIP entity. This again will come from University of Maryland Medical System. However, this again, they're only playing that administrative role. So they are only signing the contracts with you all and sending out the payments. Any program questions, policy questions, just general questions about the program, please send it to our EQIP inbox, equip@crisphealth.org. We're happy to help you there. I want to ensure that University of Maryland, who has very kindly stepped up to lead the process of care partner arrangements, doesn't get deluged with a bunch of questions about the program. Signature of these care partner arrangements is due by December 31st for participation in performance year 1. So performance year 2 expansion, I've already seen a number of emails, so very exciting, but please send comments if you have official comments by November 30th. So within the next month or so, you can send them directly to me or to that EQIP inbox. It'll be easier for us to kind of manage this new development process on that end. As Jean mentioned, we're willing to meet one-on-one with stakeholders and interested parties to discuss questions about proposed episode additions. I think we have some really great starting points for this analytic process now, just based off of this meeting today. But as thoughts come in, as you digest this with other partners in your practice, please feel free to send those along. And then again, our timeline for finalizing this list would be March of 2022, though we have to work this through with CMS as well. So we'll start to get more indications early next year. So with that, I'll see if there are any late breaking questions, but thank you everyone for your time this morning and involvement in EQIP throughout the enrollment process. I think we've had a fairly smooth process for this first enrollment, but we appreciate everyone working through things with us as we get it up and working. So with that, we can close out a bit early unless there are other thoughts.
All right, well, thank you, everybody.
Great,
Thank you.
Bye.